Okay, it's interesting to hear everybody else's models, but it's very interesting to hear that we've got some common themes running across. The project that I'll be talking about is patient-centred care for over 75 plus population. And fingers crossed this works. If you're not feeling well, don't look when I change slides because it's very motion focused. Okay. So obviously I'm from the Gold Coast Primary Health Network. Too soon. Everyone knows that where we are because we've had a high profile recently with the Commonwealth Games. We're probably a small PHN that goes down to the New South Wales-Queensland border up to Ormo, so past the theme parks. We have one local council and one hospital health service, so we're quite fortunate with that. It isn't just beaches, high-rise buildings and theme parks. We do have beautiful hinterland, and we do have very rapidly growing areas on the northern corridor. So we have a lot of high-growth areas and needs for that population. And because we have mild winters, it becomes a very popular retirement place. So just due to timing factors, the only thing I wanted to highlight is that we've got about 600,000 patients and greater than 16% of that population is over 65, so we do have a significant ageing population. We have 191 general practices on the Gold Coast, of which 141 of them are submitting data to Gold Coast Primary Health PHN every month. So you don't really need a crystal ball to know what the future is at the moment. We've heard a lot about that in the last 2 days, and I'm sure we'll hear more. The shift to population health approach to managing healthcare, patient-centred care, healthcare homes has been a very big topic. Quality practice incentive payments are changing how practices are going to earn that vital income from practice incentive payments, looking at sustainable and affordable and equitable healthcare. And this move towards managed, proactive and coordinated care with a focus on team-based care and the expansion of the role that the nurse can play in that care. So I'm not telling you anything much different from what you've heard today. So why change? Why do we need to change? That didn't work. That worked. So how can we deliver a patient-centred, proactive, coordinated approach from a population health perspective in primary care? Currently there's no process to identify those patients at high risk, and I know there's risk stratification tools being developed for the healthcare homes, but we're not a healthcare home site. So how do we actually work out who those people are and who's at high risk of going to hospital? Care plans and health assessments are generally medically focused, and as other colleagues have spoken about today, they're very much disease focused, looking at diabetes but not looking at the person. The goals are set for the patient, and they're generally medical focused to achieve a clinical target, but there's no action involved for the patient to actually achieve those targets. Is this really addressing what our patients need and what they want in healthcare, especially when we're looking at 75 plus, where we're not likely to cure, we need to support. So we've had some opportunities on the Gold Coast PHN to try and, we've looked at opportunities and how we can actually progress a project in this area. So we did some research, and I must admit this has been going on since 2016 to get to where we are now. And we've had different teams working in it, doing different parts of this project. My main role's been on the practice implementation, but I'll give you some history about how we got to this model. So we did some research to try and identify a tool that could actually risk stratify patients. And the Johns Hopkins ACG tool was the tool of choice that we've been looking at, that could potentially meet our needs. This is a validated tool used internationally, particularly in the UK, Europe and USA. It's not being used in Australia, although there is one general practice in Sydney who was trialling it, but not in a PHN perspective where we could actually look at bigger practice populations. So they were very keen to partner with us to modify the tool to meet the Australian market, because overseas they have hospital data linked with their patient data, and we don't have that at the moment. But so there was some modification that needed to be done. We targeted 4 practices on the Gold Coast to trial using this tool, and they had a lot. We chose them because they had a long history in quality improvement activities, strong clinical governance, and they all used different clinical software to give us the opportunity to test what this tool could do. There was a lot of data mapping required because you all know we use different coding languages in our programs, so that really took quite a lot of time and effort to do that, to get to manipulate the data to get it in the tool. And then once we did that, we used the tool to identify, so the tool had the capacity to identify patients with multiple comorbidities and rated their risk of healthcare utilisation and risk of hospitalisation in 5 bands. So we had this data, what do we do with it? How do we actually do something with this information and develop it into a project? So we were fortunate again to identify the opportunity to implement a previously trialled patient-centred approach for complex patients who were 75 plus to target the reduction of potentially hospital avoidable admissions and to improve quality of life. And this was done in South Australia by a GP there. I don't know if the South Australia knows him. He did it in his own practice, and it was only over a very small patient population, and he really wanted to roll it out more broadly to see if it would work somewhere else. He's currently employed at Bond University, and we had links with them, and that's how we all got together. He actually then went through the approval process for ethics, so it's actually now got a research component as well. So using the tool, we identified potential patients, so we provided a list. The data comes to us in a de-identified format with a code that goes back to the code, goes back to the practice, and they then identify who the patient is, so we don't get any identified data. Practice actually were asked to look over and validate these patients to see if they are actually probably their high-risk patients and the ones with multiple comorbidities, and most of the time we got it right. Oh, I better rush. But sometimes we got it wrong, and it was probably some of data quality. How many minutes have I got? 5. Okay. So the model of care, what did we do? There's no point in developing a new model of care unless there's a financial model to back it up, to implement it in general practice. I'm happy for all this to be shared so that people can see the model, but basically we had to use existing item numbers. Particular note was we tried to force or push the 10997 for the nurse to be really involved in the care coordination component. We really encouraged 3 monthly reviews for these patients because they were complex, and rather than try and do everything every visit, we split the 3 monthly reviews into a seasonal focus. So spring we focused on improving coding and data quality. The summer focus was end-of-life planning. Autumn was prevention, immunisation, falls risk and so on. And winter's going to be looking at the burden of care, which we're heading into now, de-prescribing and reviewing the amount of appointments that these patients have to attend, which is very similar to what other people have spoken about. Which ones are adding value and which ones should be kept in primary care to keep the patient well. I'm really going to rush because there's a video I want you to see. Lots of practice support. One of the key things was actually we had monthly teleconferences, which was mainly nurses who attended. So even though it wasn't intended to be a nurse-led project, we had the nurses driving it at the practice level. GCPHN also did some funding for non-Medicare activities, and that was basically related to the research component, collecting data and consenting. So what did we learn? Well, I'd like to say we had the perfect model and it all worked perfectly, but what we did identify was this shift to patient focus. The actual templates that we used had minimal medical terminology in them. The nurses were expected to identify what the patients want and then to set goals on that. It didn't happen. We did get a slight shift at the end because we were collecting the de-identified care plans and health assessments, but we've got a long way to go. And that's part of the learning. We only started it in 4 practices, but we were hoping that, the lessons from this, we can actually make it work more efficiently and be more proactive moving forward. So those are the things that we found. We did identify that nurses had a knowledge and skill gap in setting those meaningful goals and having those meaningful conversations. They just didn't have the skills, and even GPs didn't have those skills as well. So there's just a quick video, I'm hoping this works, of a practice experience in the project.
My name is Sue, and I'm the practice manager at Harmony Health Medical Centre on the Gold Coast. This is Lucy, one of our registered nurses. The practice has been involved in the population health project from early on in its inception. And we're here today to answer a couple of questions about our experience of the project. The first question we were given was, what was the key learning for us from the project? So first of all, regarding templates. These evolved along the way as they were utilised and then suggestions were made for improvements. Secondly, we found that patients didn't always see the value of attending for regular 3-monthly maintenance appointments rather than attending for an acute episode. But we did find in these regular appointments that health issues were often picked up and investigations were initiated. The project highlighted for us the value of advanced health directives, and Lucy will talk a little bit more about that. We found that keeping track of patient appointments and recalls needed a lot more than our usual reminder system. We reviewed our system and we made changes for the project, and some of these changes will be used for other patient groups in the future. We also found that we needed a dedicated admin team member to oversee the admin side of the project and liaise with other team members. So essentially we found that the admin side of the project was tweaked along the way. So at this stage we're very keen to find out what the data shows when the project ends in June. So over to Lucy.
The second question was, how has this changed your approach to the care of the 75 and over patients? We already use care plans and health assessments for most of our complex elderly patients and had a good reminder system in place. But we changed the review period to 3 monthly reviews for those with a high risk of unplanned visits and with complex care needs. Our previous templates were pretty good, but the changes we'll make will be to actively discuss the Advanced Health Directive and Statement of Choices. We found that this was really valuable for the Pop Health project, and we'll request patients' thoughts on the medications more, just as an opportunity to identify concerns and to educate them. Our care plans already did prompt for checking immunisation status, but we liked the seasonal focus and just going through different things with each care plan. And we're going to change them to prompt nurses and GPs completing care plans to learn more about what community activities and groups patients engage in, and use this as an opportunity to encourage and educate patients on what's around, what they can get involved in, just to avoid and identify isolation. And we also noticed we picked up on quite a lot of carer stress, both for the patient and their families, which we were able to address. So I hope you find our feedback helpful, and thank you for your time.
Last slide. One other nurse said to me that she found that the key learning for her was she was actually able to work to her full scope as a nurse, doing the nursing things and letting the doctor do the doctor things. and she was one of the ones that struggled taking this on board. And after about 7 months, that's where we got. So slow changes, but we were making progress. Evaluation, formal evaluation won't be until later than we expected, with this finishing in June. But it took so long to enrol patients and get the process going that we're actually extending it. We're going to have focus groups with questionnaires, staff and patients, and particularly the patients, to see if it changed their quality of care or their experience. So looking at the quadruple aim, how that's affecting in that place. Lots of training opportunities for our nurses now, and we're looking into how we can get that moving. And hopefully in the future we'll see standardised coding across Australian programs and actually internationally, so tools can be used everywhere to better identify patients at risk. Thank you.